would like to call the chairpersons, Dr. Chandraya V, who's the Professor of Medicine, SIMS and RI, Bengaluru, and Dr. Kiran Nidagundi, who's the Consultant Physician and Diabetologist at Suban Diabetes Center, Bengaluru. We welcome you on stage, doctors.
Welcome to the next session. We have my good friend Dr. Basavanagowda. He was my UG classmate. We know him for last 50 years. We are together, and is a very good teacher, good clinician. Patient care and students care is his priorities. For that effort, he has reached the post of Vice Chancellor of JSS Academy of Higher Education, and is a good orator. With that, will request Dr. Basavanagowda to start his talk.
My slides. Good afternoon to everybody. We are already 45 minutes late, and I know there is a pressure on me for the subsequent speakers who are eager to finish their talk as early as possible. I'll promise you that I'll complete my talk in 14 or 15 minutes maximum. Srinivas Murthy keeps testing me with very unusual topics given. The topic given to me is when risk factors collide, that is uncontrolled diabetes, hypertension, dyslipidemia, presenting with dizziness, what next? That is the topic designed to me. Let me tell you why this topic is important, because cardiometabolic risk factors are very often known to coexist. Diabetes, hypertension, dyslipidemia, they all are known to injure the vascular health and accelerate atherosclerosis. And dizziness, don't write it off as a symptom and try to pick up your pen and prescribe one or two medication and misinterpret it as vertigo. It could be a warning signal of vascular event. So clinical challenge is it benign symptom or is it an impending catastrophe in a given patient? Having said that, each one of these risk factors, we all know how they badly affect the vascular health, endothelial dysfunction, vascular remodeling, plaque formation, and combined effect is accelerated atherosclerotic risk, possible stroke risk, and CAD risk. Having said this, this collision of risk factors is a conspiracy between culprits, and ultimately you have those outcomes in terms of dizziness could be a first symptom and deceptive symptom of a vascular event in the neurological practice. Clinical question in this situation would be, is it a benign symptom or early warning sign? So understanding the cardiometabolic interplay, the summit itself is cardiometabolic summit. And this is a case example I'm giving you, and I'm closing my talk, leaving it to you to what to do in such a situation. So we need to understand the interplay, which helps to move from symptom-based treatment to treatment on vascular risk prevention. Having said this, let me give you a very, very simple common case adhering to this title of the talk. A 58-year-old man present with OPD with sudden dizziness. Current comorbidities, he is diabetic for 12 years, hypertensive for 8 years, dyslipidemic, but he is not bothered to take statins as advised. So he is on metformin, glimepiride for diabetes, amlodipine, metoprolol, often prescribed combination for hypertension, and non-compliant with statin therapy. With this background, on one day while walking, he developed sudden onset dizziness, mild unsteadiness while walking, no loss of consciousness, no chest pain. His BP was uncontrolled, and sugars were also not controlled, and on neurological examination had subtle gait imbalance. This is the typical case scenario which is adhering to the title of the talk assigned to me. His lab data showed clearly that uncontrolled diabetes and dyslipidemia with LDL of 168, and clinical question is this a simple vertigo or an early warning of posterior circulation ischemia? The key question would be, is it vestibular? Is it metabolic? Is it cardiac? Is it vascular? So a clinician has to be very, very sharp and alert when he deals with dizziness, which is very often misrepresented by the patient, misinterpreted by the clinician. Many, many things are presented as dizziness to a clinician by a patient. It could be a mild hypoglycemia expressed as that. It could be a drug effect, which was given for treatment of hypertension, a drug given for painful neuropathy in diabetes. They can also produce dizziness, and more importantly, posterior circulation stroke, TIA, can bring you a patient with dizziness. Having said that, these are all the differential diagnosis for dizziness, starting from mild hypo to TIA in the posterior circulation, arrhythmias, orthostatic hypotension due to dysautonomia, hypoglycemia, electrolyte imbalance, antihypertensive medication, anti-neuropathy medication, all can bring a patient with dizziness. We should not brush it aside as a simple symptom. A detailed history and symptom triggerers has to be assessed. Measure blood pressure. Always when somebody has come with dizziness, please don't just be happy with one BP reading in supine position. Most often, you better check it in sitting, preferably supine and standing. Neurological and cardiovascular examination, very quick examination, look for nystagmus, look for gait, look for the other symptoms of the red flags, I will tell you. Laboratory evaluation, check blood glucose, of course you will do it automatically. HbA1c, lipids, and perform an ECG to know arrhythmia, bradycardia, and so on. Look for red flag symptoms, I'll tell you that. And those who have red flags, will need to subject them for MRI and 4-vessel Doppler. Cardiac causes of dizziness would be arrhythmia, silent ischemia and diabetes, left ventricular dysfunction. Then arrhythmias can be picked up by Holter monitoring and echocardiographic evaluation for LV dysfunction. In autonomic neuropathy also, patient can come to you with postural dizziness, misinterpreted as vertigo, orthostatic dizziness, postural hypotension can be easily demonstrated and picked up by checking the BP in supine standing, exercise intolerance, and silent ischemia. These are the red flags. If somebody has come with dizziness, he may have 1 or 2 or 3 risk factors. If he has ataxia, if he has diplopia, if he has dysarthria, if he has severe headache, if he has demonstrable imbalance, please don't prescribe stogeron and Vitawat and send him. He has to be carefully evaluated. You may be dealing with a posterior stroke, circulation stroke. Why? Because posterior circulation strokes are often, there won't be focal weakness and in the early phase, and mimics vertigo. CT is often normal, and the gold standard would be MRI, DWI, and good standard investigation is that. Why it is important is because it accounts for 20 to 25% of the strokes, posterior circulation strokes. Symptoms often include simple dizziness and imbalance, frequently misdiagnosed as vertigo, and requires early recognition and imaging. This is the flow chart. A patient who has uncontrolled diabetes, hypertension, dyslipidemia, check blood glucose, measure BP, supine standing, neurological examination, and if they are positive to conglomerate, and if there are red flags, please suspect posterior circulation stroke, image him with MRI, MRA, and admit him and initiate treatment. If they are not suggestive red flags, you need to be further evaluated. As I told you, red flags are these many: ataxia, diplopia, dysarthria, hypotension, severe headache. Okay? So, further investigation will be A1C, lipids, electrolytes, Holter, and manage them. And ultimate goal in treatment is to manage vascular risk aggressiveness or aggressively to prevent stroke. Having said that, you need to risk stratify. We all know that. Assess the ASCVD risk. Check the target organ damage. Look for LV hypertrophy and carotid plaques with 4-vessel Doppler. And microalbuminuria and retinopathy has to be checked as surrogate markers. So management strategy would be optimized glycemic control, adequate blood pressure control, high intensity statin therapy if required, and antiplatelet therapy to prevent stroke. So integrated cardiometabolic care is the key word that is required when there is a cardiometabolic risk collision presenting with dizziness. Treat the patient, not the isolated disease or a symptom. Don't treat dizziness or vertigo and prescribe some medication. Use drugs with cardiovascular benefit. Examples, okay, would be SGLT inhibitors, GLP-1 receptor agonists, and ARBs and statins, and drugs to alter hemorrhagiology. Lifestyle modification is the fundamental. Most important thing that we often need to know is this quarter, drug-induced symptom of dizziness. Please check the drug list, what he's taking, especially antihypertensive, especially the anticholinergic drugs which are given for neuropathy treatment, and gabapentin and pregabalin. They can all produce dizziness in a given patient. So please go through the drug history before you pick up your pen and prescribe some medication for the symptom. And key take home from my presentation is dizziness in diabetes should not be dismissed as a simple symptom. Look for red flags. If there is positive, investigate. And be careful in analyzing. Multiple risk factors amplify the risk of atherosclerosis. Rule out posterior circulation stroke in a patient who presents with dizziness. Adopt aggressive cardiometabolic risk control. To end, in a high-risk patients, dizziness is not a symptom to reassure, but it is a signal to investigate. With that, I thank you for patient listening, and thanks Srinivas Murthy for making me to talk on a little unusual topic, a case-based topic, which you day in and day out, you'll be seeing somebody walking into your clinic with dizziness. So keep these points in mind. Ultimately, you have the right to perform your duty, but not to the fruits of your actions. There is a famous statement in Bhagavad Gita, but this Highlight Summit is designed with a statement of there is nothing more pureful than the knowledge. Let all of you go with a better knowledge, with all the deliberations by experts who are coming to make their presentation here, interact with them, learn, go home, make the patient's health better, and you give better healthcare delivery. Thank you all.
Thank you, sir. Indeed, it was an excellent talk on how to manage dizziness in metabolic disorders. So we are running short of time, so sir will be available here, so we can ask any questions.
You can interact with me directly.
Sorry for that thing, sir. Deepak, what? Please.
So that was the genuine question asked by sir.
Thank you, sir.
So thank you so much, speakers and chairperson. We would request you to move to the selfie area, which is outside the hall.